Good morning, everybody. Thank you for joining us this morning. I am Brooke Thomas. I'm your CME specialist for Community Hospital. And this morning, we have Dr. Garrett McCoy presenting to us on pink scaly rashes and when to refer. A few housekeeping items before we start. If you have any questions for Dr. McCoy, please add those to the chat and we'll answer those throughout the presentation. There are no disclosures by Dr. McCoy. Community Hospital designates this program for a maximum of one AOA Category 1A credits and will report CME and specialty credits commensurate with the extent of the physician's participation in this activity. Community Hospital also designates this live activity for a maximum of one AMA PRA Category 1 credits. Again, physicians should claim only the credit commensurate with the extent of their participation in the activity. Dr. McCoy grew up in Spokane, Washington. He went to Brigham Young University for his undergraduate degree, and he went to medical school at the Medical College of Wisconsin in Milwaukee and also completed his dermatology residency at MCW. Dr. McCoy did a fellowship in Mohs micrographic surgery and dermatologic oncology in Philadelphia, Pennsylvania at the Dermatologic Surgery Center. He moved to Grand Junction in July of 2023 to join Mountain West Dermatology, where he does most surgery with some general dermatology mixed in. Dr. McCoy met his wife, Allison, at BYU, and they have 4 kids, ages 4 to 11 years old. He has 2 older brothers who are also physicians in Grand Junction. Justin is sports medicine, and Jordan is an orthopedic surgeon. Okay, Dr. McCoy, the floor is yours.
Okay. Well, thank you for having me. When I asked what topics you wanted to hear about, it was rashes and then also lentigos versus melanoma. And those are two pretty big topics. So I decided to focus on one and as I said earlier, to Dr. Doyle, if you want to have me back to talk about melanoma or something else, I'd be happy to come back another time, but I don't know that I could fit everything into one lecture yet. So I thought today I'd focus on rashes and kind of take an aspect of rashes that may not sound super exciting, but it's very important, and that's talking a lot about scale. Scale on a rash is something that we use a lot in dermatology to help us figure out what it is. And I don't know that it's something that's necessarily talked about unless you're like in dermatology grand rounds and getting down to the nitty-gritty details of what the scale looks like. So we'll go through some of that. Okay, I don't have any disclosures. And so when we talk about pink scaly rashes, we call those papulosquamous eruptions. So the papulo, that's referring to the papules, or the feeling that that they're raised, and squamous, it talks about the scale. The objectives will be to be able to define what a papulosquamous skin disease is, to discuss scale and its role in the differential diagnosis. I also want to talk about when to refer to dermatology. I know sometimes that can be difficult, and then go through a couple of cases of different papulosquamous diseases. All the cases discussed are fictitious and for learning purposes only. So when we talk about a papulosquamous eruption, so it's a different group of dermatologic diseases, and it's papules or plaques. So the primary lesion is a raised lesion. So if you rub your finger over it, you can feel it. And then it also has a secondary change of the scale. A lot of times in dermatology, if any of you did rotations through dermatology, we're very, I don't know if you'd say we're kind of anal about the description of things. And we use, macules, papules, plaques, and all these things. And part of the reason is that as we describe a lesion, or sometimes as I'm looking at it, I'm describing it in my head because it takes me down different differential diagnoses and paths based off the description of what the lesion is. So a lot of times, when I would be early on in my dermatology residency, I'd be struggling. A lot of times, some of my best attending physicians would just stop me and just refocus me and say, what's the primary lesion? And so that's a good place to start. Can you feel it or do you not feel it? And then after you get through that primary lesion of, is it a macule or a papule? Is it a patch or a plaque? Then you can kind of look at some of the secondary changes, and it helps you to kind of focus on things. Um, so there can be various kind of forms of this. So the top picture there, that's tinea. So it's a papulosquamous eruption. You can feel it, it's got some scale to it. And then the bottom one, that's guttate psoriasis. So it's also, pink and scaly, but the scale is different than the one above. Um, so there's various forms of pink scaly rashes. So here there's AKs. The scale on an actinic keratosis is very rough. So, we always talk about like a sandpaper feel to it. So that's the type of scale you have on that. You have psoriasis. It's going to be more of a silver scale, silver to white scale, and it's not that rough that you have on an AK. Here's Tinea amiantacei. This one is a very, as you can see, it's kind of a clumped together scale. It just forms, this is not something you'd see every day, but you can see in psoriasis, you can see this, you can see in seborrheic dermatitis in some of the worst cases. In seborrheic dermatitis, you have a kind of a yellow greasy scale that forms a lot of times in the kind of the corners of the nose, eyebrows, behind the ears, and on the scalp. Um, you can have, sorry, there can be other types of scale where you can have like the lesion, and then you have like a trailing scale behind where the border of the lesion is. And then in this one is pityriasis rosea, where you can have like a collarette of scale, so scale that's kind of around the top of the lesion. It's a very fine scale. And then you can get like a fish-like scale or like plate-like scale here, and this is like some very dry skin or ichthyosis or ichthyotic type skin there. So one of the branch points in dermatology as we things and we go, is it eczematous or is it papulosquamous? Because that can take you down two different roads. And so um, an eczematous rash is very different than a papulosquamous rash. So maybe again, oftentimes you look at it and you're like, well, it just looks red and scaly. An eczematous rash, though, it's going to be a lot more ill-defined. So if you look back at some of these, you can tell, where it kind of starts, where it ends. Whereas on an eczematous rash, it kind of like fades off. It doesn't have a very defined area. You kind of look and it's like, well, there's that, and there's a little bit over here, and it's hard to tell where it starts and where it begins. Um, and then you get some different secondary changes that are associated with eczema that are different from the papulosquamous eruptions. So in eczema, you can find things, like I said, it's ill-defined. You can see fissuring, vesicles, erosions, secondary infections, lichenification, and hyperpigmentation that's often associated with eczema that you're not seeing as much with the papulosquamous eruptions. So fissuring, so you get those linear erosions. A lot of times it's associated with bacterial infection, very painful typically. And this is going to be more of an eczematous type reaction. Vesicles, this is in really inflamed skin. So something like this, these are two really bad cases of contact dermatitis from poison ivy, poison oak. So you get so much inflammation. It brings in so much inflammation and swelling that it actually just ends up kind of pulling the skin apart because of so much swelling that you get these vesicles. As you can see, there's like a little bit kind of a linear distribution, and that's showing that it's something that you came in contact with. You can get erosion. So this is just the superficial part of the skin comes off. The loss of the vesicle roof can leave these erosions, and you're seeing a lot more kind of this wet erosions in eczema and not so much in papulosquamous eruptions. And this would be eczema herpeticum. So you can see these erosions of the vesicles that you get from the herpes virus. Again, these are just the top part of the skin coming off. So usually this heals without scarring. You can also get crust. So you get this serous exudate that forms as these scabs, and you can get a lot more crusting in like an eczematous type disease than papulosquamous. Lichenification, so the exaggerated skin markings, and that shows a lot of rubbing is going on, scratching, and chronic over time. And you're going to see this more in an eczematous condition like atopic dermatitis, nummular dermatitis, more than you're not going to see this in psoriasis. It's going to appear different. So when we get to papulosquamous, so it's a dry, scaly, and it's often very well defined. And you can get a subacute to chronic papular plaque. So you can see, here, these kind of look a lot different than you're seeing like this red well-defined scaly rash. So I'll go through various cases. So if you have a 34-year-old female presents with an explosive rash in the last month, it's not very itchy. She's recently diagnosed with hypertension, started a new blood pressure pill, doesn't know what it is. If they're anything like in our clinic, they'll say it's the blue tube. When you ask them what medication they're on, or so for you, maybe they might say it's the white pill, which really probably helps, I'm sure. So this is what the rash that she comes in with. So again, you have these well-defined pink, red, scaly plaques, kind of a white silver scale. I think if every rash came in looking like this, you'd probably not need me because you could probably come up with the fact that of what this is. But you can see that there's different kind of types of scale here, even in this, where it's like the left there's it's a little bit of scale. It's not super scaly. The right, there's a little bit more scale, and then you can get something that's very scaly, all the same condition. So what would your diagnosis be? Yes, two, psoriasis. Good. So psoriasis, it's a dry, silvery scale, papules and plaques. Most common areas would be scalp, extensor surfaces, low back, umbilicus. You can get nail changes. And so when I'm looking at this, if it's like something that I'm like, well, I think it's psoriasis, not quite sure. A couple areas to look, like top of the butt crack is a good place to look because a lot of times it can be there. The other thing that can help is looking at the nails too. And it doesn't help every time, but sometimes you can see these pits in the nails, and that's like, oh, okay, well, then that's psoriasis. So that's like a simple thing that can help. Again, that probably happens 20% of the time that you can get nail changes. So it's not every time, but it's just one more piece to the puzzle that can possibly help you to kind of get the whole picture. Um, yeah, so that would be what I'm looking for. And then just looking at the right areas too. Sometimes too, and it's like, well, you got this rash and like, oh, it's really bad on my scalp. And then you look at the scalp and you can see this big plaque with a ton of scale on the scalp, and that's going to be more psoriasis. The other thing about psoriasis is it's a clinical diagnosis, meaning I can biopsy psoriasis, but the amount of times it comes back as like psoriasis is not actually very common. Like it might come back as like, well, it's psoriasiform with some spongiotic dermatitis. And so you can't just biopsy it and be like, oh, perfect, it's psoriasis. It is a clinical diagnosis that needs to be made. There's variants of psoriasis, but again, it's a lot of different sizes of pink and scaly with that kind of silver scale. So you can get guttate psoriasis. Um, and guttate means raindrop. And so it's these small kind of raindrop shaped lesions. Um, as far as guttate psoriasis, when you're looking at someone and they come in and they have a rash kind of like this, that's guttate psoriasis, you want to ask them about any recent sore throat infections, because strep can really trigger this. In fact, oftentimes, and especially in children, strep, if you clear the strep infection, the guttate psoriasis will go away. Sometimes it does lead to kind of plaque psoriasis down the road, or it never quite goes away and can be plaque psoriasis from there on out. But that can often, if you clear the strep, you clear the psoriasis, or if it doesn't go away, it at least gets better. Any new stressors, new medications, family history, all of these things can be associated with guttate psoriasis. Pustular psoriasis, this one can be trickier. So you get these kind of red scaly plaques with these, we call them lakes of pus. And sometimes if you see this and you see the pus, the knee-jerk reaction may be it's infection. We have to treat with antibiotics, which I would encourage against if you're seeing a lot of like pus in this manner, because you can see the same thing induced by medications. And we always have those stories of consults we get where they've been trying various medications and then they call us and they're like, we keep giving them antibiotics and it's not getting better, and it's because the antibiotics are driving it. And so if you see these kind of lakes of pus, I just encourage you, just give me a call, and we'd be happy to see them and kind of help you out determining, is this psoriasis or some of these other medication induced reactions, or is this an infection? Inverse psoriasis, this one can be trickier because it's in an intertriginous area. There's a lot more moisture, and sometimes the scale isn't as evident because it's just moist, and so it doesn't have a chance to kind of dry out and get scaly. But if you're noticing that they just have these kind of well-defined plaques in the intertriginous areas, inverse psoriasis should be on the differential. Sometimes seborrheic dermatitis can be hard to differentiate between this and seborrheic dermatitis. Typically, again, I would recommend that you kind of look in some other areas too, like the nails, look at the scalp and see if there's anything else that can kind of clue you into, is this seborrheic dermatitis or is this psoriasis? Um, and then palmoplantar can be tough. Palmoplantar, oftentimes it can look like a fungal infection. It's typically just, again, on the palms and soles. Sometimes you can even see in there, there's almost like some pus that's forming, some um, uh, yes. And then on the feet, again, it can be tough to differentiate psoriasis or not, but those are some of the variants. So what other questions would you think about when you're talking about review of systems with someone with psoriasis? And joint pain is kind of the big one. So it can definitely be osteoarthritis. About 5 to 30% of people with psoriasis can get psoriatic arthritis. Um, but it tends to be more of a symmetric pain. Usually it's in the smaller joints. So on the fingers, DIPs, PIPs, wrists, lower back, SI joints are common. You can get some swelling and deformities, and the pain is typically worse in the morning. Sometimes it might not even necessarily be a pain as much as it's just morning stiffness. How long does it take you to get your fingers and joints moving in the morning? If it takes you 90 minutes to really kind of get things going, that's a good indication of morning pain or stiffness. And you can often see this with very limited skin findings. In fact, 10 to 15% of psoriatic arthritis can appear before you even have any skin findings of psoriatic arthritis. Um, as a primary care doctor, if you have someone that's newly diagnosed with psoriasis, what may be a lab that you would consider? This is kind of an easy question, I guess. But you might consider something like a lipid panel. And the main reason is um, what we're finding with psoriasis is it's not just an inflammatory skin condition, but in general, it kind of leads to a heightened inflammatory state. And so any modifiable risk factor that you can manage, you should probably be a little bit more aggressive in managing that. So that's talking about lipids, blood pressure, other things like that, because we do find that if there is more than 10% body surface area of psoriasis, they have increased rates of metabolic disease, heart disease, and other things like that. So um, again, anything that you can be aggressive in helping to modify. And of course, I know that there's changes in the literature all the time on lipids and how to manage those and how aggressively. So that would be where you guys would excel in helping with that. Um, as far as triggers go, medications. So as far as like blood pressure medications, so like a beta blocker that can exacerbate it. It doesn't always. I wouldn't encourage you to not use a beta blocker unless you're seeing that they're telling you that their psoriasis is getting way worse. Strep infection, other viral illnesses like we talked about can trigger it, stress, HIV, and then associated, like we said, with metabolic syndrome and depression. Um, and so, sometimes it's hard to know if this is the chicken or the egg, because in psoriasis, there are high rates of depression and there are a little bit higher rates of inactivity. So are they having issues with their psoriasis leading to depression and activity, or, that leads to the metabolic syndrome, or it's hard to know exactly what starts it all, but those are kind of the associations. Um, as far as medications go, there's another mnemonic you can add to all the mnemonics you forgot about since med school. But NSAIDs, ACE inhibitors, antimalarials, beta blockers, lithium, terbinafine, and a big one, I guess, probably if I could pick one that you should remember, would be steroid withdrawal. Um, you can see a lot of like a pretty bad rebound effect if someone has psoriasis and they're put on like oral steroids. You put them on a 5-day course of steroids and their psoriasis clears up, but then it like boom blows up right afterwards. So you got to be careful about that. Um, And then as far as treatment for psoriasis, so typically, if it's not super widespread, you can start with topicals, so steroids. And with a steroid, you got to go mid to high potency. So you're looking at either triamcinolone, 0.1%, or clobetasol. My go-to is typically clobetasol, just give it to them. Um, and then vitamin D derivatives, I honestly rarely use those because they're outrageously expensive, and we have a lot better drugs. Calcineurin inhibitors like tacrolimus, that's good if there's intertriginous areas or the face. Light therapy, that's a good option. And, we used to use it a lot more, but with biologics, we kind of no one wants to come 2 or 3 times a week to our office to get light therapy. But in some settings, it can work. I had a patient that um, he was immigrated from Africa. He had really bad psoriasis, went to put him on a biologic, and he had latent TB and hepatitis B and all sorts of other things. And for him, it was just easier just to come to the light booth and get light therapy than it was to go to infectious disease and get all these, and kind of go through them. And so we did light therapy, and he did great. He loved it. His skin cleared up great. Other systemic medications, so methotrexate and cyclosporin, those are typically more historical medications in psoriasis now. Not to say that there isn't a place. Cyclosporin will clear psoriasis really quickly, but it's a pain to put people on. And so now we use the biologics. So we used to use TNF inhibitors a lot more. Now we're even getting away from those to where we use anti-IL-17s, IL-23s. If you watch TV, I'm sure you've seen a commercial about all of them multiple times. Um, they work incredibly well. The side effect profile is very small and limited. And so some of the anti-23, IL-23s especially, it's like, well, if you put them on that and their psoriasis doesn't clear, then it's not psoriasis because they work so well. Um, so as far as for you as a primary care doctor, you see someone with psoriasis and what do you treat and when do you refer? So I would say if there's less than 10% of the body surface area, they don't have any joint pains, you can go ahead and treat it. I would start with a topical steroid. If you're thinking about whether you should refer for psoriasis, if it's covering more than 10% of the body surface area, if there's any joint pains, if you've tried topical steroids and it's just not cutting it, or if they have a disease that's really affecting their life. So, for example, I had a patient that he didn't have a lot of psoriatic disease. It was just on his palms, but he was a drummer. And he's like, I can't drum. And so, on someone where we might just be trying topical steroids for him, it was like, all right, we got to figure this out a little bit better because he couldn't drum. Um, Other things you can do before referring or as you refer, if is get a couple labs. So one would be like a quantiferon gold, or or a TB test of some sort, hepatitis C and hepatitis B. The only reason is because if they come to me, I'm probably going to put them on a biologic, and in order to start them on a biologic, those are the labs we're going to need. So if they're already done, makes the process a little bit smoother with the prior authorizations and everything. Um, but that's so yeah. And then as far as topical steroids go, the way I look at it is, this is in general, not just for psoriasis. I always pick a high potency, a mid potency, and a low potency topical steroid, and I just use those as my go-to. As you can see, there's a million choices of topical steroids and various potencies. So I just go high, mid, low, and I just have my three that I go to. And then if the insurance rejects one, then you can always go for a backup. But really, the only one they ever reject is the high potency one for me. So in general, for high potency, my go-to is clobetasol. I use clobetasol on the hands, feet, and scalp, or if there's a thick, large plaque or lichenified skin. So this is where I use it. If you're using like triamcinolone on the hands, typically isn't enough. Just the skin is so thick on the hands and feet that you need to go pretty high potency. And as far as like atrophy of the skin on the hands and feet, again, the skin is thick enough that you could use clobetasol a long time on the hands and the feet, and it's not going to cause a ton of atrophy. If you're concerned about it, you can kind of give them some guidelines and say, you can use this for 3 weeks, and if it's not cutting it after 3 weeks, talk to me, or, and then you can refer to dermatology. But again, you can use it a long time. As far as mid potency goes, triamcinolone 0.1% is my go-to. I've never had that one rejected. Clobetasol sometimes, and if they reject clobetasol, then I'll go like augmented betamethasone. Dipropionate would be my next go-to. But mid potency triamcinolone, that's great for trunk and extremities. And then low potency would be hydrocodone hydrocortisone, 2.5%, and that's for like face, genitals, and intertriginous skin. Sometimes I'll get people and they say that their doctor gave them hydrocortisone 1%, and in general, that's just doesn't do much. You could give them lotion and it'll probably do about the same. So if you're gonna go for a steroid, I'd say go to at least the 2.5% hydrocortisone. Um, and again, as far as atrophy goes, if you tell people, use this for 2 weeks, they're not going to get atrophy unless they're using clobetasol on their face. But if they're using it in these locations, they're not really going to get atrophy from using it for 2 weeks. So you can say use it for 2 weeks. If you need it longer, take a break. Because if you give your skin breaks in between of even a couple days, then the atrophy really doesn't develop. And then as far as potency goes, ointments are better than creams, are better than lotions. So typically I try and tell my patients, if you're okay taking an ointment, I'll give you an ointment. If you don't like the greasy feel, then a cream would be the next best. Okay, second case. So 30-year-old male presents 2-week history of rash. He seems to start with one large insect bite on his neck, and then otherwise he's pretty healthy. So you can see these kind of ovoid pink, and if you look, they'd have a little bit of scale, very fine scale on top of them. So in this one, um, not going to see something as widespread as far for like tinea, psoriasis. It doesn't quite have that thick. It's more like you can barely feel this one. So it's not quite as thick as psoriasis. Lichen planus, it's not really that purple polygonal. It's not super pruritic, which if it's not, then lichen planus is unlikely. And again, it has very defined lesions, so it's not atopic dermatitis. So this one's going to be more pityriasis rosea. So pityriasis rosea typically has that herald patch. So a lot of times they'll say, well, I got this spot and then these other things came. So it's this ovoid, finely scaled, thin plaques. Often in a Christmas tree pattern, you can mostly truncal. Sometimes you can see this inverse pattern as that bottom picture shows. Lasts typically 3 to 8 weeks and then it goes away. So this is the way I find is the best, like that helps me diagnose it every time. Like I see it, and when I see it kind of on on these pictures, I'm like, well, I'm thinking about it, and then I look at their back and I see this, and it's like, oh, this is pityriasis rosea. As you can see, it follows like a Christmas tree distribution. It follows what we call the Blaschko lines. So the Blaschko lines are the lines where your skin migrated out from the neural crest, and it comes out and during embryonic development, and these are the lines that the skin follow during development. And as you can see, this follows that, and you see like these ovals, and the ovals almost follow in that same pattern. And when you see that, it's like, oh, okay, this is pityriasis rosea. And then you just reassure. Um, we don't really know. I think we talk about, well, maybe it's viral because it does have seasons. Like we typically see peaks in the spring and the fall. And, I think as typical in a lot of things in medicine, when we don't know what it is, it's probably viral. And so you don't really need to treat it. Most of the time, it's pretty asymptomatic. But if you see this, that's the main thing is like, well, is it itchy? If it is, you can do antihistamines and like a low to mid potency topical steroid. If it's really itchy, you can do light therapy. I've never seen it be really itchy. There was one study that showed erythromycin helping it go away after 14 days. The challenge with this is, was it really the erythromycin or did it just go away because it goes away on its own? So I would say when to refer. If it's not gone after 8 weeks, then you can refer, but most of the time this just clears up on its own. But again, biggest takeaway I'd say is look at the back and that kind of distribution with those ovals that are just kind of following those lines is very key. Okay, got a 25-year-old male presents with a rash all over, started a few weeks ago. It's slightly itchy. He's healthy. He has an allergy to doxycycline. He was treated with that for an STD last year. He works as a bartender, has a new sexual partner. So you can see there's like pink, this like finely scaled rash. You can look at the back that doesn't have that Christmas tree pattern. Um, so, again, I would say I've never seen tinea just be so many little spots like that. Psoriasis, it doesn't quite have that same scale that you would see in psoriasis. Lichen planus is going to be a little bit more purple. Wrists, ankles are more common. We already talked about pityriasis rosea, that it's not. And so this is something that we all don't love to see, but we are unfortunately seeing more of it. So syphilis. Um, my so when I went to Philadelphia, I did a year of general dermatology and then my fellowship after that. And in my 1 year of general dermatology in Philadelphia, I diagnosed syphilis 3 times, which I hadn't in residency. One came as primary syphilis. It was a 70 to 75-year-old male who was happily married, and he came in with this. ulcer, painless ulcer on his penis. I honestly didn't know what it was, so I biopsied it and came back as syphilis. Told his primary care doctor to so we could get him treated, and we were both a little surprised. But again, this is how syphilis is now. It's coming back, and it's something you have to think about, even in someone that might surprise you. Usually, this will occur 2 to 3 weeks after exposure, heals within a few weeks without treatment, and it can go unrecognized. Then you can get secondary syphilis. So this is hematologic or lymphatic spread. It's 3 to 10 weeks after the primary infection. You can have low-grade systemic symptoms like fevers and myalgias. You can get lymphadenopathy, and you can have some mucocutaneous findings. So on the patient, I had another patient, my first week out of residency, who came in with this huge body rash, and he had these mucus patches on his mouth and his tongue. Um, and you can get condyloma lata in the genitals. Sometimes people will mix that up with other genital warts. And then you get this, palm and soles on the rash on the palm and soles with this fine collarette of scale. Um, so there it is again, palm and soles, little collarette of scale on there. You can also get this moth-eaten appearance of alopecia that can occur. Um, and so this was one of my patients, and so I apologize for the bad picture, but this is one of my patients in Philly, and she came in with this rash, and she shows me her palms and soles, and in my mind, I'm like, this is syphilis, and I'm like, oh, are you married? Yeah. I said monogamous relationship. She kind of looks at me funny, like, yeah. I'm like, okay. And in my mind, I'm like, shoot, this is syphilis. And I'm like, okay, well, this could be a lot of things, but one of the things we don't want to miss is syphilis. And so she was like a little surprised, but she's like, yeah, why don't we check that lab? So we got an RPR, and of course it was syphilis, and she got treated, and that was the last I heard from her. This was another patient. This was the like I said, the first patient I saw with syphilis. So as you can see, this widespread rash. Again, on the back, it's not following that Christmas tree pattern, so I'm not thinking pityriasis rosea. It does have some fine scale, and it just has a funny appearance. I don't know. It's just almost like a leopard. I don't know, but it's a unique rash that you just don't see very often. Um, so it can lead to tertiary syphilis. Once it gets there, that's a little beyond skin disease. And so that's where we kind of stop. But this can take years down the road. There's various tests for it. So dark field microscopy, I think early on is one of the best. RPR, kind of in secondary syphilis is typically the highest yield. So, and then the treatment is just inject them with penicillin. So there's various tests for that. There's a big algorithm that we don't have time to read. And then as far as syphilis goes, it is on the rise. This is a really old chart showing it's on the rise. This is more recent. I got this from CDC website, and also I looked at Colorado kind of health department website, and they're showing that in from 2019 to 2023, we've been an increase by 120% of syphilis. And even in Mesa County, they have some data on that, and it's definitely increasing here in Mesa County. Among females, it's increased by about 320% in that same time period. And right now, that's excluding congenital syphilis, which is where they're kind of having a lot of issues right now, is with congenital syphilis too. So it is important to try and catch these, especially in our young female population that's having kids. Um, so I feel like even when I was in residency, it was kind of like, yeah, syphilis, you might see it. But even since a few years of residency, it's like, be on the lookout. Okay, you have a 55-year-old male presents with a 2-week history of rapidly spreading rash. He thought it might be dandruff at first, but it seems a lot worse. He has a history of diabetes. He's on lisinopril and metoprolol, family history of diabetes. So here you see this kind of widespread rash, and it's kind of like the reverse. Normally you see like skin with some rash, and this is more like rash with some skin. So it has these islands of sparing. You can get follicular hyperkeratosis. And this is pretty rare. If you see someone with a rash this widespread, I would just say, give me a call. Whether it's psoriasis or PRP, if it's this widespread, we should probably be seeing them in dermatology. But this is pityriasis rubra pilaris. It can spread head to toe. like I said, you can get this follicular hyperkeratosis, and you can see like in that bottom picture, there's kind of this perifollicular erythema. Like I said, there's more of like it's when I don't know if you've rotated in dermatology or been to dermatology grand rounds, but I remember when I was a first year, it'd be like, you're describing something and you're like, oh, it's purple, and then the attending stops you and they're like, no, it's violaceous, and you're like, that crap is the difference. And sometimes with color and dermatology, it can be anal, but this one is actually one where it does. I found that it matters. It is much more of like an orange red, even I like feel dumb even saying it, but like salmon. Like it totally has this very different color of red to it than normal. Um, you can also get this waxy keratoderma. So it almost looks like they have like a sheet of wax over their hand, and you can also find nail changes with it. So you can see on the palm soles, it's like there's like a sheet of wax over their hands, and it's like this salmon colored plaque with this really waxy look to it. There's a bunch of different subtypes. It occurs in children all the way up to the sixth decade. Type 1 is the classic type, usually goes away in 3 to 5 years, but it can be very problematic and distressing. There's not really any great treatments. Part of it is that we just don't see it that often enough to probably do a good study to figure out what's going to be best. But you can try systemic retinoids like Accutane or acitretin, methotrexate, TNF alpha inhibitors, I think kind of the newest that show the best promise. Like I said, as far as it goes for primary care, if you're seeing a rash that's this widespread, just give me a call. We'll get them in. You have a 75-year-old male complains of mildly itchy rash that's been getting progressively worse over the winter. He's tried cortisone 10. He's on donepezil, early dementia. Um, Again, this is more kind of intertriginous chest areas. Again, it's not that round, well-defined like tinea corporis. Doesn't quite fit psoriasis, not scaly enough. PRP doesn't not widespread enough. As we talked about pityriasis rosea, it's not not following that pattern. So seborrheic dermatitis is going to be kind of the main thing. So you get these pink yellow well demarcated plaques with a yellow greasy scale, and that's the big thing is that yellow greasy scale that's important. It's usually in sebum rich areas. You got the scalp, central face. So typically the way I tell my patients is like eyebrows, sides of the nose, behind the ears, in the ears, scalp. And then rarely you can get some on the central chest and kind of the armpits. Um, I, you know, there's a change in the skin surface lipids. And what I find is I tell my patients, I have to explain to them what this condition is because otherwise we'll treat it and then they'll come back and they'll say, well, I did what you said, but then it came back. And so I have to tell them what this is, and sometimes I have to tell them what it is a couple times. And by spiel, and if you dive deep into the literature, it this is kind of a good thought. The literature is like doesn't nail down the same thought, but I tell it this way, and I find that it helps the patient understand a little better and help them to treat it. But essentially, we all have yeast on our skin. It's part of our normal flora. Seborrheic dermatitis, the way I like to think of it is just it's our skin reacting to the yeast. And so our skin reacts to the yeast. It causes inflammation. Inflammation leads to the skin kind of uh, going through like kind of growing, proliferating, and then you get more scale because of the kind of the inflammation leading the proliferation of skin. So we have to do two things. Number one, get rid of yeast. Number two, decrease inflammation. Okay. And so that leads to how you treat it. Number one, anti-dandruff shampoos. They all kill yeast. Zinc parathione in Head and Shoulders kills yeast. Selenium sulfide in Selsun Blue kills yeast. Ketoconazole kills yeast. And so that's like your maintenance. You use that as a maintenance. If you stop that, the yeast comes back. The seborrheic dermatitis is going to come back. And so I have to tell them that we're not curing you. We're aiming to control it. And this is going to be your maintenance. This is going to be it. Like typically a shampoo is easy. If they have it on their face, I say, when you rinse your hair, wash your face with it. That can help. Wash your armpits, wash your chest. And then I give them a tube of hydrocortisone 2.5%. And you say, when it's, especially when they're seeing you and it's really flared up, say, do this for a week with the shampoo, stop the hydrocortisone in a week, just keep going with the shampoo. If it flares up, then you use the hydrocortisone. Some people don't like to wait for it to flare up. So I say, okay, if you don't want to wait, if you don't like it when it flares up, do the hydrocortisone once a week. Okay, don't do it every day, but once a week, Sunday nights, you put the hydrocortisone on those areas where it's going to be a problem. Doing a steroid once a week is not going to cause atrophy. Then sometimes that will keep them like, okay, then they're happy. So I kind of give them, I like to tell them, here's the tools. I give you the tools. You figure out how your body works and you figure out how to use it. I counsel them on not overusing the topical steroid, but essentially the maintenance is going to be the ketoconazole or the over-the-counter anti-dandruff shampoo, and then the flare-ups are going to be the topical steroid. You can see this in infants and older adults. I don't treat it in infants. Typically it goes away. Older adults, in infants, you're mostly treating the parents. In adults, it can be kind of an annoyance. There's various triggers. It can often be associated with Parkinson's disease and HIV. Why? We don't really know why, but if you look for it in Parkinson's patients, you'll probably see it pretty bad, and it can be kind of distressing and tough to treat in those conditions. So again, various shampoos, and then if they have it in other areas that they don't want to wash with the shampoo, you can give them a tube of ketoconazole would be fine too, but then low potency topical steroids. Um, all right, we got a 42-year-old female, complains of really, really itchy spots on the legs, hands, keeps her awake at night. History of previous heroin use, has been clean for 3 years. This one is going to be lichen planus. So I'm kind of rushing a little bit. I'm running out of time here, but there's the 5 Ps of periodic purple polygonal planar papules. You can get the shiny purple with a fine kind of white linear scale over the top. You can get it on the extensor arm. So like wrists, ankles are super common locations. The mouth. So again, if you're trying to figure out if this is lichen planus, one of the places to look is mouth and genitals. Those are 2 places where it can come up. And a lot of times in the mouth, they don't even realize they have it. And then nails. You can also look at the nails. You can get this pterygium is what it's called. And it's a inflammation in the nail matrix that causes this really weird scarring and kind of that kind of, you can just see that kind of scarred down nail almost. There's a lot of variants. So you can get mucosal, you can get it on your hands, you can get it on the genitals. There's an erosive type in the mouth. So people will come in, they're like, oh, my mouth, it's like falling apart. It's just eroded and it's painful. Um, and that's probably one of the more distressing ones. And then again, there's all sorts of other kind of hypertrophic. I had a patient come in, they thought it was a bunch of squamous cell carcinoma on the legs. Turns out she had lichen planus in the genitals, and it was just a hypertrophic LP, which is really hard to differentiate under the microscope from a squamous cell carcinoma. So if you get a patient and you biopsy something and it comes back as squamous cell carcinoma, but it doesn't make sense because they're just like, it's everywhere on their body, you might kind of rethink that one a little bit. But yeah, you can see that bottom left picture. That's the oral lichen planus. That's not the erosive type. Um, you can get Kebnerization. So where you get trauma, you can get these lichen planus plaques that pop up. So you can see kind of like a linear spread, but that's more from getting cut. And then this is Wickham striae. So this is kind of that fine white linear scale that you're seeing in between kind of some of the plaques there. There's the oral variant, and then you can see the nails too in there. Another test that you should consider would be hepatitis C. So, it's associated with hepatitis C and some vaccines, and you can get esophageal involvement. And in the mucosal ones, it can lead to squamous cell carcinoma, so important to treat that. Typically, topical steroids, phototherapy, acitretin, those are some of the more common treatments. And we're getting in severe cases, you can use methotrexate, cyclosporin, or Cellcept. But for as far as for you, trial a high potency topical steroid, and if that's not working, you can refer. So here you have a 45-year-old male complaining of scaling, itching on his hands and feet. Starting over the counter antifungal, but he's breaking out in rash all over. Things he could be allergic to the cream. These pictures, what they're trying to show is 2 feet, 1 hand. That, for whatever reason, is very typical of tinea. I don't know why it's 2 feet, 1 hand, but that is what's common. But you get these pink plaques, well demarcated, the scale. And again, we have all these things. I'm running out of time here, but depending on the area, we have a different name for it. It's from dermatophytes. If you do any KOH scrapes in your office, this can be helpful. I find that when I scrape eczema, and I scrape tinea, it's a very different scraping. Eczema is going to be flaky. You scrape it off, and it's all these flakes that come off. And tinea is like wet. It looks like it shouldn't be quite wet, but you kind of scrape it and it clumps together, and it's more of like this wet scale. And so when I'm scraping it, I can almost tell that it's going to be tinea versus it's going to be, oh, this is just eczema. Um, if you're getting a hair culture, you got to get some hair in there. So we'd take a toothbrush in our peds derm clinic and we'd rub it on the top of these kids' head and get actual hair out, or else you're not going to get it. And again, you just want to treat it with antifungal. As far as kids go, just one thing, if you're treating kids for tinea capitis, oftentimes when we would see anyone that was sent over by pediatricians or family medicine, if they'd started them on griseofulvin, but they didn't get better. And most of the time it was they weren't given a high enough dose and they weren't given it long enough. So you want to go 20 to 25 milligrams per kilogram daily over 6 to 8 weeks that's the microsized griseofulvin. Um, so we'll just those are kind of the main things. Id reaction, that's just um, if you're seeing two morphologies, like, well, they have tinea, but now they have this eczematous rash, that's what we call an id reaction. So it's an eczematous reaction distant from the site of infection or inflammation. So you can get it from contact dermatitis. So I saw once a patient that I did surgery on. He had a big contact dermatitis on his contact dermatitis from bandaging on his shoulder, and he broke out in a rash everywhere else. You can see it from tinea. So a lot of times kids with tinea capitis, they're going to have rash elsewhere, and it's not fungal, it's just this id reaction. Stasis dermatitis, so in your patients that have really bad stasis dermatitis, they can break out in rash elsewhere. So you treat the stasis and that will help the rash. Scabies can often lead to it. So these are kind of the papulosquamous disorders. There's various, I mean, we kind of went through each scale and how they're slightly different. We'll kind of skip through these ones. There's some mimickers. So like we talked about with Dr. Doyle, I talked quickly about T-cell lymphoma. This is typically in like a bathing suit distribution. If you're seeing plaques in the bathing suit distribution, you can trial a topical steroid. If it doesn't get better, send it over to us. But if you're seeing nodules in there, just send it to us right away. Crested scabies. So this looks like wet sand, like it legitimately looks like wet sand. Typically, they're going to they're immunosuppressed in some way. I saw this once at the VA and I was looking at the patient and I'm going, what is this? And then I looked at his elbow and I was like, that looks like wet sand. And I was like, oh my gosh, it's crested scabies. And this just means normally in scabies, you have like 10 to 100, scabies. This is like hundreds to millions of scabies. Other mimickers, palms and soles, Rocky Mountain spotted fever is really the only other rash on the palm and sole that we see commonly, other than like, palmoplantar psoriasis. And this is more petechial than this Colorado scale. So this is my contact information. There's my email, my cell phone number. Please, write it down, take it down. I am always happy to answer any questions. If you need a curbside, if you just want to talk it through, give me a call. Or if you're like, I need to get someone in urgently, give me a call. My schedule is, I know, and typically in Grand Junction, getting someone into dermatology is a challenge. My schedule is a little bit better for getting people in urgently than some of my partners because I do Mohs surgery pretty much every day. It's a little easier for me to kind of like, okay, well, I'll put someone in between my Mohs cases. And so, you know, don't hesitate to reach out or pick up the phone and call. I found that if I have one of your patients and I have an issue, I typically just pick up the phone and call because it just goes a lot. It's a lot easier than trying anything else. So don't hesitate to reach out to me. Again, text me, call me. I'm happy to help out in any way I can. Yeah. Are there any questions?
Excellent job, Dr. McCoy. Thank you so much. If you have a question, please add it to the chat and we will read it out. We'll give it just a second.
Thank you very much for the program. It was really good. And today is Healthcare Education Professionals Day, so timely topic. And on that note, I would just like to thank Brooke. She keeps this place running. She gets all the CME activities going, and it's not her only job. So thank you, Brooke.
Thank you so much. Oh, you guys are wonderful. Okay. Nice from Dr. Arja. Nice job. Thank you for being here and welcome. Thank you, Dr. Arja. All right, so I'm not seeing any other questions. Just a note, I don't know if you had recognized or not, our next CME was supposed to be Dr. Omar McTabi, and we had to reschedule him for May 30th. So he will be bumped to a little bit later in the spring. Other than that, thank you again, Dr. McCoy. Really appreciate you coming in and sharing all of this. Oh, from Dr. John Freckleton. Super. Thank you, Garrett, and for Brooke. Thank you, Dr. Freckleton. All right, if that's everything, thank you so much. Stay warm out there and wear your sunscreen.
Always a good plug.
Have a great day, everyone. Thank you.